our last class, we talked about something called lipoatrophy, which is loss of fat. In this class, we're going to talk about something different called lipohypertrophy, which is an accumulation of fat. And unfortunately, sometimes with protease inhibitors, that fat accumulates in spots where patients don't obviously want them. One area, it could be behind the neck, and you can unfortunately see some patients who develop this dorsal cervical fat pad. Men especially develop within their abdomen, they accumulate fat in that area. Now, sometimes it depends on our patient, but some of our patients will go ahead and have cosmetic surgery where the surgeon will remove that fat behind their neck. Certainly that's going to be very difficult to do that in the abdomen because the fat that accumulates in the abdomen is more the organs themselves, not below the skin. But behind the neck, we've had a few patients who've had liposuction done. For the abdominal fat, people have tried different things, diet, exercise, certainly sometimes that works. I even had a case where a patient had so significant abdominal fat that it was affecting their breathing, and the patient was hospitalized. They're trying to figure out what the heck is going on, and when they did a CT of the abdomen, it was accumulation of visceral fat. So in that particular patient, we had to switch out the antiretroviral. So we stopped the protease inhibitor, and we put them on a different drug. And several months later, the patient was better. So that's always a possibility if there is a chance that the patient can switch. Now, in addition to fat accumulation below the skin and behind the neck, sometimes you can have fat accumulation within the arteries and the veins, so elevations in lipids, and these effects are associated with cardiovascular complications. Now, we know that some of the protease inhibitors, and in fact, abacavir is also coming into the news more and more lately, has been associated with certain cardiovascular complications such as heart attacks and strokes. Now, our patients, in addition to being on these medications, will also have other risk factors for cardiovascular complications. So that could include smoking. That's a very common risk factor. Age, again, as I mentioned, elevated lipids, whether it's directly from the drug or is it genetic. High blood pressure, diabetes, coronary artery disease, and in patients who have a family history of premature cardiovascular complications. So all of these risk factors certainly have to be monitored and assessed when you see a patient who is on medications for HIV. Certainly, we like to monitor their lipids as well as blood glucose, and Alton's going to talk about the sugars in a second. We can encourage lifestyle changes, so diet, exercise, even stopping smoking goes a long way to obviously stopping some of these long-term cardiovascular problems. And certainly, if that doesn't help, there are certain medications that are less cardiovascular, that cause less cardiovascular complications than some protease inhibitors. So we might have to actually switch out the regimens if that comes to that. Now, if we do manage the cardiovascular complications, certainly we'll use the American Heart Association practice guidelines, which are available easily off the internet. So going along with this theme, cardiovascular issues, we can talk about a little bit about hyperlipidemia. There are the three categories, so protease inhibitors, non-nukes, and nucleosides all have a certain degree of elevations in lipids. Now, some within those categories, some of the drugs more than the others. Now, of the protease inhibitors, Alitra, also known as lopinavir, ritonavir, Lexiva, Norvir, especially when you're using Norvir at their full doses, the 600 twice a day, and as well as Actavis, all tend to have a greater incidence of elevations in triglycerides, especially triglycerides. And within the other category, which we talked about during our last presentation, Zestiva tends to have a little bit more elevations in lipids than nevirapine or Viramine. And then within the nucleosides, we talked about Stavudine having a little bit of a complications with hyperlipidemia. Now again, how do we manage these things? Lifestyle modifications. This is the first thing we resort to. So diet, exercise, and exercise just doesn't mean just going up to the post, going to your mailbox and coming back. It actually means exercising.
That's my exercise.
That's Alton's exercise.
As we can tell with the difference between me and you.
So my exercise would be actually going out, walking 30 minutes 3 times a week is generally what we preach to our patients. Now, whether that happens or not is another story. Certainly, that's the type of exercise you want to encourage. Now, if we can switch out the antiretroviral, we would. Now, there's certain within the protease inhibitor class, there are certain PIs that are less likely to cause elevations in cholesterol. So the one that we often think about is atazanavir or Rayataz. Also, darunavir is another one that tends to be very lipid-friendly as well. So both of those are potential ways you can manage this by switching out. Now, the problem you run into is in patients who've been on therapy for a long, long time, say several years, and their viral loads are controlled, they're doing fine, their CD4 counts are fine, they don't want to switch. So they're not comfortable because they're afraid that, if they're going to switch, is my whole therapy going to affect them. Well, in those patients, we will often treat their lipids. Certainly, we use the NCEP guidelines. Now, keep in mind that one of the common classes of drugs we use to treat lipids is statins, and there are certain statin drugs you do not want to use that will interfere with your protease inhibitor. So the prime example is simvastatin, also known as Zocor. So Zocor is actually contraindicated with our protease inhibitor, so you should keep that in mind. Now, the ones that you'll commonly see in our HIV patients are pravastatin as well as rosuvastatin, which is also known as Crestor. Now, with Crestor, keep in mind, at least with Kaletra, the upper dose for Crestor is 10 milligrams. So generally, we don't go more than 10 milligrams. At least that is for sure for Kaletra. Now, in our clinic, we sort of use that information for other combinations that include Norvir, because remember in Kaletra it's both lopinavir as well as the ritonavir, which is the Norvir. So is it the Norvir that's having a major effect, or is it the lopinavir? That hasn't really been elucidated as well. So we still limit our maximum dose to 10 milligrams, even if they're not on Kaletra. If they're on a boosted PI, we still don't go more than 10 at least.
So let's talk about diabetes and insulin resistance when associated with protease inhibitors.
Actually, Alton, if we could interrupt for a second. We have a question from the web.
Hi, Web.
The question is, are there any times that you might dose reduce to improve side effects and monitor the patient's progress?
So the question is, can we dose reduce the antiretroviral regimen to lower the side effects or minimize the side effects? Now, generally, we do not do that, and the reason why we don't do that is because we need the dose that's appropriate for the patient to have effects on the HIV itself. So if we lower the dose, even though the side effects might be lower, then you're going to compromise the regimen. So generally, we don't do that. That's a great question, though.
Cool, great. So when we're talking about diabetes, whether you're on a protease inhibitor or not, you're going to always hear the following symptoms from a patient. Now, that is, number one, let's talk about the signs of hyperglycemia. Name me what is polyuria. That's a fancy word. What is that? Increased urine. That's right. People going to go to the bathroom a lot, right? What's polydipsia? Thirsty. That's right. And what's polyphagia? Y'all are doing it now. Oh, eating a lot. You're hungry lots, right? So patients are going to present with those, or they're going to present with fatigue and weakness. Now, if you are dealing with a population group that's disproportionately affected by diabetes, what group would that be? What comes to the top of your head? African American, that's right. So, and which one right now is being disproportionately affected by HIV and AIDS? African American. So you need to be conscious of more than one disease state in your patient, okay? Also, so if you go to the doctor, they're going to always say how to fix this. My doctor says it to me every time I go to the doctor. What's he always going to say? Lose weight and do what else? Exercise. Diet and exercise. Says it every time. And that's a wonderful way to help manage insulin and diabetes. So if you can't, you may have to switch the antiretroviral or the protease inhibitor if that's the cause. And if you're going to treat diabetes, you're going to treat diabetes just like you do anything else according to the American Diabetes Association practice and guidelines. So that's how you would handle diabetes with a patient with protease inhibitors.